Okay, take it away, Josephine.
Thank you. All right. Hello, everyone. Sorry I had to move this a bit earlier. I had got work at 1:15, so got to get off a bit quickly. But hopefully we can get through all of this today. So, all right. Little preamble. Sorry, I know it's a lot of slides. I didn't want to miss anything, so I just put everything in there. We won't have time to go over all of it, obviously, but some of the things are in there just for your reference. So I won't go over it, like anatomy. There's some pictures and things, but you've got it there in case you need to check up on it later. Also, I've sort of done it as a question, explanation, answer sort of format. So you can do the questions as we go along. I hope you have enough time to answer them, but it might be a bit quick just because there's a lot to get through. And all of these things will be in the post slides that I'll upload after this as well. And also the questions all came from past exams on Aquila. So hopefully it'll give you an idea about how much you need to know about each topic and what's sort of more important than other bits.
Push it up.
All right, let's get started with anatomy. So here's your first question. I will give you 30 seconds to have a go at this yourselves. You can just write down the answers and then we'll go through a bit of an explanation. Also, if you have any questions, I'll probably answer them while I have questions up for you as well. All right. I know there's not a lot of time, but hopefully you've at least had a read of the questions there. This is a bit of a typical anatomy question where they're just a bit mean, but getting you to show what you know, especially with foramen and things. So I'll start off with bones and ligaments. This one's just for your reference, bit of a picture. No point in me just reading out all of the different bony landmarks, but the important one I think to know would be the linea terminalis here, which again comprises of the sacral promontory, the arcuate line, and the pectinate line.
Oh my
here.
god, this question's like.
All right. Excellent. And I'll go through the answers at the end of each section, so I'll pop them up for you. So here are the pelvic shapes. I've never really seen it in a question, but they really drummed it into us in anatomy, so they might have a question on it. Pretty self-explanatory in that gynecoid is more female. Think gyne, gynecological. It's better for childbirth because it's the widest pelvic shape. And then the android is the most common male shape because it's best for bipedal movement, like walking and running and things. The worst one for childbirth is the platypeloid one, this one here, because it's the narrowest. But males and females can have any of these pelvic shapes. While we're comparing male and female pelvises, I do remember seeing a question on our exam last year where it had either a male or a female pelvis, and you had to tell us which one it was. So I always got this one confused, but the way to remember it is that if it's wider, it's going to be female generally. Everything is wider and it's supposed to be more oval shaped like this, whereas the male pelvis is more heart shaped. So I don't know if you can trace that line there. You can sort of imagine that it looks a bit like a heart. There's a pointer out there. All right. Pelvic lines and spaces come up a little bit. As I was saying before, this linea terminalis is basically the landmark between the false and the true pelvis. And then you've got the pelvic outlet at the bottom, which is between the coccyx, ischial tuberosities, and the pubic symphysis there. All right, pelvis during pregnancy. I don't know if we covered this, but I saw it in a past revision lecture. So that one's just for your reference. It's basically a measure of how wide the pelvis is. So therefore, how easy or hard childbirth's going to be. But this one we did go over, and this is the plane of least dimensions. So that's between the pubic symphysis, the ischial spines, and S4, S5 here. And that's the narrowest part that the baby's head has to squeeze through during childbirth. So to make this process a bit easier, the corpus luteum during pregnancy produces relaxin, which, as the name suggests, relaxes things. So it relaxes the ligaments. And that means that the sacrum can tilt forward, and like a fulcrum, the coccyx will then tilt posteriorly. And as you can see, that'll open that space up a little bit more. And that means you also get more lumbar lordosis as well. So that's sort of bowing in of your spine here. All right, here are some ligaments. They're just there for your reference. Really, I don't think it's that important, to be honest, but something you just need to memorize. What is important is the foramina and the contents in that. So the most important one is the greater sciatic foramen. And as you should know by now, it's divided by the piriformis muscle. It goes right through the middle, and you've got your suprapiriformis and your infrapiriformis foramen. Suprapiriform foramen is pretty easy to remember because it's just superior gluteal artery, vein, and nerve. That's all that runs through there. And then pretty much everything else goes through the infrapiriform foramen. Important things to know here would be inferior gluteal, inferior pudendal, and sciatic nerve. These ones are pretty small, not really that important. Important with the inferior pudendal vessels is that it leaves the pelvis here. So it's actually, it's a bit hard to see in this photo, but it kind of comes out here, and then it goes back in the lesser sciatic foramen. So that's when it re-enters the pelvis, and you've also got the obturator internus tendon there and nerve. And then the last foramen to know is the obturator foramen. Pretty self-explanatory because it just has all the obturator stuff. All right, and here are your answers. People sent them through to me. Perfect. So you can quickly tick those ones off. And let's go on to spaces in the pelvis. So this is just for your information, but why this is important is this clinical point here. So when in catheterization, usually in males, you can get a rupture here. So if you imagine when you're putting in the catheter, you have to hold the penis vertical, so it's like this. So it's pretty easy then getting the catheter in because it's just a straight line here. But then at this point here, there is a kink or a turn in the urethra. And I don't know if you push too hard or you don't quite get in the right angle, you could rupture the bulbar urethra there. And if that happens, the urine then can't get out through the hole. You can't get normal flow of urine. So instead, it's going to go through your break here, and it's going to travel into that third layer in here, which is the membranous layer of subcutaneous tissue. It's probably the most important one to know here. Why is it important? Because this layer is actually continuous with the abdominal wall and with the dartus fascia of the scrotum and penis. So if you get that rupture, the urine will flow through here, and you'll probably be able to feel it or see it there. That's also a bit important if you've got infection. So that's where infection can travel as well if you've got continuous layers. This one's just there for your reference, really, really small, not so important. But maybe just keep track of where that internal pudendal artery and branches are as well. More pouches. This one's pretty self-explanatory. I'm sure you guys will know you've got pouches between your organs, basically. So the males, you've just got the bladder and the rectum, so you have the rectovesical pouch. And for females, you've got a uterus in between. So you've got vesicouterine and rectouterine. And the rectouterine is called the pouch of Douglas as well. And these are important because they're the most posterior or inferior part of your abdominal cavity when you're standing up. So if you've got infection or blood or something like that in your abdominal cavity, that's where it's going to deposit in those spaces. All right, that's just there for your reference. And here's your next question. I'll give you 15 seconds for this one. right, excellent. So that one's a bit of a just memorize thing. These are the pelvic floor muscles, nice picture for you with the urogenital anal triangles. Not much to say other than just know it, but to be honest, it's not so important. Like know your levator ani muscles, definitely, but the rest of it, not so clinically relevant, I suppose. Why do you need to know the levator ani muscles? For fecal continence. So the puborectalis part of the levator ani is like a sling around the rectum, and when it's tensed, as you can see, it kinks the bowel, so feces can't just escape freely. And when that relaxes, then your rectum will straighten out and you can go to the toilet. And know your innervation, S234 keeps the poo off the floor. Incontinence after childbirth. So as you can imagine, childbirth, squeezing a massive baby's head through your vagina is quite difficult. And sometimes you can get tears in the process. And usually when there is a tear, it'll go down the middle. And why is that bad? Well, all of your muscles, all your sphincters are like a ring, right? And so they're going to contract like this. Now, if you imagine you've got a tear in there, then you're trying to contract like this, and you're not going to get a nice contraction there. So you'll get incontinence, basically. And if you think that can go all the way to the anus, and it's just not fun. So sometimes if they think it's going to be a difficult birth, they'll actually create a cut beforehand, and they'll do it mediolateral. So all you really need to remember is that it's mediolateral. Basically, just so it's not midline. It's better to be a bit on the side than straight down the middle. And there's your answer. All right, UTIs, very short point. Females have more because they've got shorter urethras and it's closer to the anus. Easier to get bugs up there. Here's another question for you. I'll give you 30 seconds for this one. And if you want, I can zoom in a little bit. Each of these has a corresponding number, so you just have to basically match them up. Go. Sorry, probably not enough time for just 30 seconds, but we do have a lot to get through, so. Have a go. I did this one a little bit by elimination as well. So some were a bit obvious, so I could put those ones down, and then you have the ones left over, and you can just guess for those. All right, let's keep going. This one's just for your information. No point in me reading out the arteries for you, but one clinical point. 30% of people have an aberrant obturator artery, and that can cause bleeding and hernia repair surgery. Veins mirror the arteries, so that's pretty easy. And then this one, I'm sure is drummed to death in you guys as well. It was for us. Basically, your left gonadal vein drains into your left renal vein instead of the IVC. So the blood flow back isn't as great. Also, you can have something called nutcracker syndrome, which is basically the SMA coming off the aorta, basically pinching off the left renal vein. So it sort of squishes it a bit. So that means the blood can't flow back as well. So you get backflow. If you get backlog, you're going to get dilation of your veins. And in males, that's going to look like varicocele, which looks like a bag of worms. All right, and there are your answers. All of these slides will be put up afterwards as well, so you can spend a bit more time going through them. All right. Nerves. 2 more questions here. I'll give you another 20, 25 seconds. All right, excellent. This is just for your information to look up later. Now, pudendal nerve comes up a lot. I'm almost going to guarantee there'll be a question about the pudendal nerve in your paper. Remember, S234 keeps the poo off the floor, and just know where it travels. So remember, it exits the pelvis and the infrapiriform foramen, and then comes back in the lesser sciatic foramen, goes into this pudendal canal, which wraps around the ischial spine, and that's sometimes anesthetized during childbirth. And so what they're going to do is they're going to basically do this picture. They're going to go in through the vagina and they're going to feel for that ischial spine, and that's where they're going to direct their local anesthetic to target that nerve. Sensory supply is pretty self-explanatory. It's just that whole genitalia area. And motor supply, pelvic muscles and the sphincters are the important ones there. If you seriously memorize the lumbosacral plexus, you are probably an A++ student. This is pretty intense, and you don't need to remember it in the detail that you do for the brachial plexus. The only important ones to know maybe would be the sciatic nerve, because it's pretty massive, and it basically just has all of those nerve roots. Pudendal nerve as well, we just went through. Femoral nerve, obturator nerve, and maybe genitofemoral just for where it runs. I'm pretty sure I've had a question or two on that, and that it runs right over that muscle. Also, get to know this picture really well. I can't remember exactly, but I'm pretty sure one of the lecturers last year, one of the anatomy lecturers actually made this diagram. So Monash is pretty proud of their own staff. So I think they like to throw that diagram in because of that. All right. Classic nerve injuries. These ones are good to know because most of your questions will be somewhat clinically based. So femoral will be from uncareful use of retractors and clamps, and they can't stand from sitting. Sciatic nerve will be if they've been sitting in the lithotomy position, so that's the childbirth, feet up on the stirrups, legs spread for a while, and they might get foot drop. Also, you might get that shooting pain from the buttock down your leg. Obturator nerve, know that you can injure it during the oophorectomy, so OO, bit easier to remember there, and that's your adductor muscles, so it's difficult getting into a car because you've got to swing your leg inside. Genitofemoral, not much to know there other than know that it runs over the top of your muscles there. And ilioinguinal and iliohypogastric, again, not so important, but low transverse abdominal incisions, so I'm imagining something like a C-section or something, you might injure it there. And again, the pain and paresthesia is pretty self-explanatory. It's sort of like your frontal area, upper thigh, mons pubis, lower abdomen kind of area. All right, and there's just a reminder of the obturator and ovary relationship there. All right, neurovascular supply of the anal canal. I think we went over this to death last year, so I won't go over it with you, just because you've probably gone over it enough times. But just remember that middle line that divides it is called the dentate or the pectinate line, and you'll get parasympathetic or visceral above, and then, a somatic below. And there are your answers. All right, and lymphatics, seriously, all you really need to remember is generally that the outside stuff, perineum, skin, scrotum, etc., will go to the more superficial nodes, and the pelvic organs will go deeper in. Okay, I've got a couple more questions here. I'll give you 20, 30 seconds for this. All right, and let's go through it. So, should know the general reproductive anatomy by now, but I always forgot about that the faunae exist, so just know that they're there and they're pretty named, pretty self-explanatory, really. Ligaments, all right, so they will probably try and sort of trick you here in that you've got three main ligaments to know: suspensory ligament, ovarian ligament, and round ligament. Now your ovarian artery and vein run in the suspensory ligament, not the ovarian ligament, the suspensory ligament, which is here, going down there. The ovarian ligament is just connecting that ovary to the uterus, and the round ligament is just in front, basically pulling the uterus to keep it anteverted and anti-flexed so you don't get prolapse of the uterus there. And also it's kind of interesting, I find, how you've got similarities between male and female anatomy in that it runs from the uterus to the labia majora through the inguinal canal. So it's sort of like the spermatocord, but the female version. And hysterectomy, if you take out the uterus, you're going to need to cut or clamp that uterine artery. And it's important to know that it goes right over the ureter. So they're really closely related, and you remember it by water under the bridge. So the ureter is under the uterine artery. And yeah, not much else to say there. And there are your answers. Sorry if I don't give you enough time. It's just, we've got a lot of stuff to get through, so. All right. Male reproductive anatomy. Give you another 30 seconds. All right, hopefully you've gotten to at least read some of those questions. Have a bit of an idea. All right. Here's just a few, the general male reproductive anatomy. You can look over that yourself. Clinical points: scrotal evaporative cooling. So basically the panpiniform plexus, I know it's fun to say that word, panpiniform plexus, wraps around the testicular artery to keep the testes cool. That's why your testes are outside of your body, because they need to be kept a bit cool. If in varicocele, you get that dilation and you get more sluggish blood flow back. So if it's a bit sluggish, it's going to warm up more. And so your testes will get hot, and that can lead to infertility there. Male erection, there's sort of 4 sides you need to know about it. So 1, the neurological control. Most important is to know that you've got sympathetic and parasympathetic innervation. So you've got both. So it can get a bit complicated there, and you can have problems because of these 2 innervations. Some of the causes of erectile dysfunction are here, and the main ones are vascular and diabetes. So with vascular, obviously erection is all about increasing blood flow, right? And if you've got vascular problems, you're going to have blood flow problems. And so if you've got cardiovascular disease, so problems in the blood flow around your heart, then you're probably going to have it in your peripheries too. Similar with diabetes, you can more likely to have peripheral vascular problems, and also you have neuropathies, particularly autonomic neuropathies. And I'm pretty sure there's a very, very strong link between diabetes and male inability to maintain an erection. So if you've got one, you have to check for the other. Anatomy. Basically know that the deep or the cavernosa artery supplies the lacunae of the corpus cavernosa. So as blood flows in, it enlarges, and eventually you block off the draining vein, the dorsal vein. And so if blood can't get out, but it keeps coming in, it's just going to get larger and larger with more blood and maintaining the erection. And the 4th part is Viagra, which is also called sildenafil. So they might use that word in the exam instead. It blocks PDE5, which prevents the breakdown of cGMP, and so you get a sustained erection there because you're not breaking down the metabolites. All right. pretty much the same, just for information, but just to know that an erection is parasympathetic and ejaculation is sympathetic. So that's how they are both important there. Prostatic pathology, you've got benign prostatic hyperplasia and prostate cancer. So benign prostatic hyperplasia is more the transitional zone, which you can see here is really just around the urethra there. And you're much more likely to get urinary symptoms, so that anything to do with blockage, so dribbling, needing to go twice, so PUDENDAL, hesitancy, poor stream, etc., because it's compressing the urethra. And it eventually, it's somewhat normal in that it happens pretty much with every male eventually with age, just because testosterone increases the size, and if you've got a lifetime of testosterone, you'll get a increasing size of prostate. With prostate cancer, that more affects the peripheral zone, so more the outside. So it sometimes doesn't have as much urinary effects as the benign prostatic hyperplasia does. Important things to know with prostate cancer is its spread. So lymphatics, it'll go straight to those internal iliac lymph nodes, and same with the veins. The pancreatiform plexus will take it straight back into the internal iliac vein, and that goes through the sacral veins into the Batson plexus, or the vertebral venous system, and so you go basically straight to the bones of the back. That's why you get back pain with prostate cancer. And there are your answers. All right. And last bit of anatomy, male and female differentiation as a fetus. Give you 15 seconds for this one. This one's a tricky question. All right. Sorry about my terrible drawings here, but basically with gonadal differentiation, you've got two ducts. You've got your Wolffian duct and your Mullerian duct. So the Wolffian duct will become the male tubes, the Mullerian duct will become the female tubes. And the Seraia protein on the Y chromosome controls or initiates male differentiation. So if you don't have it, you'll get female anatomy. Also know the difference in that testosterone leads to your internal male genitalia, so your testes and your ducts and all that kind of thing, whereas dihydrotestosterone goes to your external male genitalia. So that's important in the congenital adrenal hyperplasia, I think, where females too can then, if you can't break down the androgens, you get a build-up of that dihydrotestosterone, and then females can be born with sort of male-looking external genitalia because of that. Also, little point, the gonads start at the 10th thoracic level and then they descend, and the testes descend during fetus and should be descended before birth. Or up to 9 months afterwards. So this isn't a teenager problem, this is a fetus or baby problem. And that's just there for your reference. And there's the answer. All right, histology, everyone's favorite. So have a go at these two questions. And if you have any questions yourselves, feel free to send them through. I do have the chat open, so I should be able to see. All right. Okay, this is more there for reference because reading out histology is like reading out anatomy, sort of not very useful, other than you just need to look at it and remember it. You should know the basics that you've got 3 layers of the endometrium of the uterus, and the endometrium got a functional layer and a basalis layer, and the functionalis one is the one that sheds each month. and you've got endometrial glands here that are sort of those invaginations down to the endometrium. All right, this one does come up where you basically get a picture of one of these stages of ovarian cycle, and you've got to tell us which one it is. So I'd know the basics in that. If it looks pretty simple, it's probably primordial, and then it'll just slowly get more and more complex. I'll go over this again with physiology. Antral is a bit easier to spot because you can see that antrum there, and if it's almost completely enclosed, the whole oocyte in the middle, then that's your Graafian or your dominant follicle there. If it all looks sort of the same color and it's all kind of big, that's probably your corpus albicans, which is the white scar left behind right at the end. And the stage before that is the corpus luteum, and that one will have the same sort of outside, all one color, but the inside will still be a different color. So it's just a way to differentiate the two. And those are your answers. All right, and male histology. There's actually quite a few questions here, so I'll give you 20 seconds for this one and then 20 seconds for the next slide. And thanks for the people who are sending me through your answers. It gives me a good idea of how long it takes. All right, and the next one. Sorry, this one has quite a few. I'll just give you a couple of seconds just so we can get moving. All right. Now, with reproductive, there's lots of sort of interconnection with histology and physiology and anatomy. So I've sort of put most of the male histology and physiology together here. So really important to know this slide, basically. It's guaranteed to be a question. Obviously, as you can see, there are quite a few questions on this. So know your spermatogenesis, basically. And the extra cells. So Leydig cells, they're in the interstitium, so they're outside and they produce testosterone. That's their main role. Then Sertoli cells are the supporting cells. We'll start with S, maybe easier to remember. They create the blood testis barrier. They express RI. They produce everything needed, and they bind the androgen. So while the Leydig cells produce the testosterone, the Sertoli cells then bind to it and grab it and use it to help the spermatocytes grow. It's supposed to have a triangle-shaped nucleus. So maybe this one here is a bit easy to see. It looks a bit like a triangle, I suppose, when you have to look at it on a slide. And with the spermatogenesis, so your first layer is your spermatogonia, and they're always there, and they divide by mitosis because males are continuously producing sperm, so that's going to continually divide. So by mitosis, you'll then make your second layer, your primary spermatocytes, and they will divide by meiosis. So now meiosis 1, so they'll divide by meiosis 1, and they'll get your second layer, which is the secondary spermatocytes. And then they will undergo meiosis 2, and then you get your spermatids. So they're all in a row, and they've got that syncytium at the moment, so they're all still connected and sharing those products, so they can all survive. And then once they differentiated, that means you've chopped off the connecting parts of the syncytium, and you get mature spermatozoa in the lumen. And FYI, fun fact, it takes 70 days for a spermatogonium to be produced, to produce sperm. It's a little interesting fact there. Genetic variation, 3 things. 1, crossing over. So that's like swapping hands. If you did this and then hands swapped, and that happens in prophase 1 of meiosis. So same in males and females. So sperm and egg will both have it in prophase 1. And then you've got independent assortment. So that's when your chromosomes will pull apart and you don't know which ones are going to pull where. So that's a metaphase. And then, of course, you've got random fertilization. You don't know which sperm is going to bind to which egg, which person, etc. So that's how we get genetic variation. Hormones. All right. In males, this is pretty simple. So your hypothalamus has GnRH, which goes to the anterior pituitary, and you've got then 2 hormones, LH and FSH. LH goes to your Leydig cells, so LL, bit easy to remember maybe, and that goes to your testosterone. Testosterone goes to pretty much everywhere, everything male, and also you get your negative feedback, so it's going to negative feedback on LH and GnRH. Then your FSH is involved in actually making the sperm, so the cells. Same in females too, in that FSH is important for starting the egg process. So that's sort of all important for starting the process. And so they go into Sertoli cells, which help. If the sperm count is too high, the Sertoli cells will secrete inhibin to inhibit the FSH and the GnRH. So you don't just make massive loads of sperm. More histo, yeah, there's sort of no point me reading it out. You sort of just have to look over it yourself. But I've got all the things you need to know about here. And it's a bit of pattern recognition too as well, being able to tell which one's which. Passage of sperm, you guys should know this one by now, and the tubes that it connects through, but it's there for your reference. Oh, and also know what the epididymis does. So there's 3 functions of the epididymis. It stores sperm. Sperm gains its first level of motility here, and fluid is also reabsorbed. So that's why you've got the stereocilia there. And that's a common site of infection if a male gets an STI or something. That's just there for your reference, really, not too important. And clinical conditions. So there's 2 to know here. 1, undescended testes, which is called cryptocordism, or however you say that. 5% of not newborn males, so remember it's a newborn problem, should be descended by 9 months old. And if it's untreated or undetected, you actually get spermatogenic failure. So you won't see any spermatocytes in those seminiferous tubules because they've all died. It's too hot in the abdomen for them. And it also increases your risk of testicular cancer. And testicular cancer is one of those ones that's really common in young people, so young men. Most cancers are older people, but testicular cancer is one of those young ones. But it's got a good prognosis with surgery if you just basically cut off the testes. The guy might not be too happy with that, but at least they'll live, I suppose. There are your answers for the first page. And there are your answers for the second. All right, physiology time. So, one question here. I'll give you 15 seconds for that one. Do we need to know the Tanner stages? So that's coming up in a second. I have a picture of it. I don't remember ever having questions on it, but I would just know a general idea, like 1 is right at the start, 5 is right at the end, and it's probably self-explanatory as to how you get there. I don't think you need to know the exact, where exactly the hair is going, but just a rough idea. So puberty starts with GnRH spikes, which are pulsatile at night, and that triggers LH and FSH to start increasing. So before all of this, you basically got nothing. It's all really, nothing's going on, but puberty, that's when it all starts. All right, it's just there for your information. Again, 10 stages are there, but I don't really need to know all the details, just a rough idea. And the average age for the starting your first period is 12.5 years old, but of course you've got variation either side as well. Male puberty as well. And the extra thing to know here is that estradiol, which is a metabolite of testosterone, starts bone maturation and epiphyseal closure. So if you get early puberty, you're going to get early closure, epiphyseal closure. So you might actually be shorter than someone who starts puberty later. Delayed puberty can just be normal, late bloomer, constitutional delay, etc. Or it can be permanent, and that's when it's called hypogonadotrophic hypogonadism. Bit of a mouthful there, but anyway. 2 causes you need to know: pituitary tumor and congenital. And the congenital one you need to know is Kallmann syndrome, where you basically don't get any GnRH. There's your little physiology point there, which isn't too important, but a bit interesting, I think, because the first symptom may be anosmia, and it just leads to a delayed or an absent puberty. And then what happens if you get this in adults? Androgen deficiency. Again, pituitary tumors can always cause it, but if you want a primary cause, you've got Klinefelter syndrome, which is one of those chromosome ones you need to know with XXY. And that's where you've got impaired Leydig cell function, which means you'll get, you won't get your testosterone, because Leydig cells make testosterone. So you have very small testes. That's sort of the main sign, and there's other things as well. And you get increased LH, because the pituitary is still trying to activate those Leydig cells. They're still trying to send that LH, but it's just not working. And there's lots of symptoms, not just sexual. There's also lots of mental and metabolic symptoms as well. All right, male infertility, just there for your reference, not really that important. And there's your answer. So it's going to be LH and FSH are likely to be low because she's only at stage 1, so she hasn't really started puberty yet. All right, oogenesis. Big topic here. Important to know at this stage is that, firstly, females start off with all the eggs they're ever going to have in the fetus. They don't make any more. So they'll do that mitosis stage in the womb, and it'll arrest or it'll stop at prophase 1 of meiosis 1. So it'll have just gotten to the start of meiosis 1. Then at puberty, it'll be reacted again, and each menstrual cycle, a group of these primary oocytes will reactivate and start meiosis again. So now they're going to continue meiosis 1, and then they'll stop halfway through meiosis 2. So they'll stop at metaphase 2. And then if the oocyte is fertilized by a sperm, it'll finish off that meiosis 2. Yeah, there's some menstruation questions. Give you 30 seconds for this one. And they do have these hormone questions for the menstrual cycle, just because that's the tricky bit, really. All right, here we go. So this is my terrible drawing that I did last year, and I suggest you do some version of this yourselves. I think they tried to get us to do it during an active learning session, but I didn't really do it till later. But it's really useful because the menstrual cycle is really an accumulation of all these different pathways. So you've got your hormones, you've got your ovarian cycle, you've got your uterine cycle, and they're all interrelated. So being able to do it yourself and relate each part to each other and see how it works throughout the days of the menstrual cycle is really useful in consolidating that knowledge and seeing what the relationships are. But for the sake of teaching, I've broken it down. So the ovarian cycle sort of went through in histology that you've got each of your follicles that are developing. I won't read through it all because that'll take too much time, but I've added in the changes each time. So plus is like what's added on every time. And as you know, the body is the most difficult education system in the world, in that if you don't make it, you die. So you'll get atresia when this dominant Graafian follicle emerges. So that's why you activate a couple of eggs, but only one should be ovulated generally. Yeah, and the corpus luteum, right, is the stuff that's left behind. So during ovulation, that cumulus orifice, the middle bit, gets shot off into and sucked up by the fimbriae into the fallopian tube, and the corpus luteum is what's left over, and that its job is to maintain pregnancy. So it's going to, number one hormone it's going to secrete is progesterone, because progesterone is like the nice happy uterus hormone. Will keep it nice home and warm for the baby. And you also got some estrogen and inhibin A and B too. Now the corpus luteum will only stick around if after a while you get some HCG, which is that thing you test for pregnancy, is that HCG. If it doesn't get that, then it will die and it'll become the corpus albicans, which is basically just a white scar. All right, hormones. So this is the complicated bit. FSH begins our cycle. So it stimulates the granulosa cells to multiply, and then you get LH, which will stimulate the theca cells to grow. So they were sort of around that nucleus there. The theca cells secrete androgens, which are converted to estrogen by the granulosa cells. So to go from theca will secrete the androgen, it will go to the granulosa cells, which will then turn it into estrogen. So that's why you can see here, you get an increasing amount of estrogen as the cells are replicating, and you're getting lots of oocytes there. Now the granulosa cells also secrete inhibin B. Now inhibin B is going to push down the FSH and LH, because remember, inhibin inhibits those hormones. And because you get that drop in FSH and LH, it's going to lead to atresia or death of all of the growing follicles except for the Graafian follicle, which is the big one that can sort of weather the storm. Once it's done that, it'll continue to proliferate and you're getting more and more estrogen, right? Now the estrogen is going to positively feedback with the LH. So I think pregnancy and all this female reproductive things are one of the only cases where you get positive feedback. So the positive feedback will lead to an LH surge, and that triggers ovulation. So the oocyte springs out and gets sucked up by the fimbriae. Now the peak's over and you're going to go back to negative feedback. So everything's just going to drop back down because you've just had this massive spike of hormones. Now, the only one that hasn't done anything so far is progesterone. It's been pretty quiet, hasn't really done anything. Now it's progesterone's time to shine. So the corpus luteum is taking over and it's going to produce all those hormones, especially progesterone. And so you get that big hump there. And then if no fertilization occurs, the corpus luteum dies, so all of these comes back down again. And now you've got really low hormones of everything. So it's going to trigger the GnRH to start to increase because of negative feedback, it's doing the opposite. So if GnRH increases, it's going to trigger FSH and LH to increase, and the cycle repeats itself again. All right, and you've also got the uterine cycle, a bit more simple. You've got your menstrual phase where that's right at the start, you're just getting rid of everything, and that's all triggered by the prostaglandins as well. So they'll go to vasoconstriction of the spiral arterioles, then you'll get not enough blood flow, so you get death to that top layer, then it'll vasodilate and you'll get lots of bleeding from that, and you also get uterine contractions. So it's just not a fun time, but it's just cleaning out everything. Then you have the proliferative phase, pretty self-explanatory, it's all growing. And here you've got thin mucus because you want the sperm to come in, right? If you want a baby, that's the time for it to come in while you're ready. And then secretory phase is going to be secreting glands and stuff to keep baby alive. And you're going to have thick mucus here because now your body thinks it's already got its sperm, so it doesn't need any more, so it's blocking out everything else. And then if there's no implantation, it'll just get rid of it and the cycle repeats. And there's another better drawn version by someone else relating that all together. And there are your answers. All right, got about 8 minutes left. All right, let's try and speed through. All right, fertilization. Because we're almost at the end, we might skip the questions for now, but you can have a look over them later. Fertilization is also tricky. So this is, I think, menstrual cycle and fertilization, I think, are the most conceptually tricky out of all of them. So you need to know the steps. One, the sperm gets up to the ampulla of the uterine tube, and that's when you get sperm hyperactivation. So it goes super fast, and so it can shoot like an arrow into the egg and stick there. And that's called capacitation. Then the sperm binds to ZP3. So ZP3 is the first thing it binds to. I remember it is like you're counting down from 3, 2, and then I don't know what 1 does, but presumably that would be at the end. Who knows? Then binding increases the intracellular calcium. That leads to the acrosome reaction. Now that leads to the sperm binding to ZP2. So 3, 2. We're now at 2, and that leads to make sure that no more sperm can bind. So I remember it as no 2 sperm can bind, because they are really annoyingly specific with the numbers and stuff there. Anyway, then you've got the sperm protein and the egg protein will bind. So I remember it as the egg has 3 letters, so CD9 is 3 letters, sperm is 5 letters, and isomer has 5 letters. So those are the corresponding proteins, so they bind, and then you get reactivation of meiosis in the egg, and then you get fertilization. Last point is that sperm-specific phospholipase C delta apparently is widely considered to be the physiological stimulus responsible for generating those calcium oscillations that induce egg activation. It's just really annoying specifics, but they do have questions on it. So here's a better, clearer version of that and some more images for you. After that, you've got implantation. So the egg now has to get from the ampulla of the fallopian tube down into the uterus and implant there. It takes 6 to 7 days. You get lots of HCG then, telling the corpus luteum to keep up the progesterone and estrogen, and then you get implantation. Causes of implantation failure and problems. One, it's just like you don't get the HCG, so the corpus luteum dies and you get menstruation. Lots of causes that can affect that. Ectopic pregnancy, so just implanting somewhere outside the uterus, usually the fallopian tube. Placenta previa, that's when it implants near the opening of the cervix, and preeclampsia is when you don't have enough vascularization of the placenta. All right, the answers are really going to speed through now. Placental development, I was really annoyed because I spent so much time learning this last year, and then there's a really specific question in the exam and I did not know the answer. So I think it was about what week does something happen. So I've got, more badly drawn diagrams of the placenta growing here. Just know that the syncytiotrophoblasts goes first, and then you've got the cytotrophoblast more on the inside. And so the mother's spiral uterinitis and whatever will grow into that syncytiotrophoblast on the outside, and then the baby, the fetus's blood will grow from the inside, from the cytotrophoblast, and then they sort of meet in that space. And by week 4, fetal blood flow has been established. So week 4, it should be ready. This is more for your reference. Placental permeability, pretty much most things can get through except for big things, so cells can't get through. And drugs like alcohol and nicotine can, and some infections as well. What is. All right. Placental hormones. There's this whole complex little, I don't know, diagram here, but the important thing to know is that progesterone, there's lots of progesterone during pregnancy, and that keeps your uterus quiet and happy and not contracting, just nice. Maternal adaptations, basically everything goes up. If you had to guess, it's probably increased. Sorry, we're running out of time, so I'll just quickly speed through the rest. Fetal kidneys, towards the end, will start secreting a lot of steroids, which helps build surfactant, so you get good lung function. And this also leads to more prostaglandins and more estrogen. So estrogen is the main urotrophic factor. So that prepares the uterus, and that stimulates everything else. And then you've got uterotonic, which induces the contractions, because tonic, think like tonic muscles, you've got tone, and that's more oxytocin and prostaglandins. And here in this whole thing, you've got heaps of estrogen. And also the signals are meant for triggering birth are meant to originate in the uterus. Various stages of labor, there's your Ferguson reflex, there's your answers, lactation, more hormones. Oops. Easy to get confused between which one's milk letdown and which one's galactopoiesis. I remember it in that oxytocin is a happy hormone, right? You don't need to be lactating to have oxytocin. Males and females do. It's happy, makes you calm, makes you more caring. If that made you make milk, then everybody would be making milk all the time. And that's kind of useless and would be a bit weird. So oxytocin just lets the milk down. And because it's the nice hormone, that'll be if the baby cries or is suckling or something like that. Prolactin is the one that goes to milk production. And you can only keep that up if you're suckling, because you can imagine if it was from crying as well, then you have like a 3-year-old or 20-year-old person still crying and you'd be making milk. That wouldn't make any sense. So that's how you can differentiate between the two. All right, answers. Menopause. Hormones are the only really complicated bit of menopause. I think of it as the eggs aren't working, and the eggs are the ones, or the whole ovaries aren't working. The ovaries are the ones that make the estrogen and progesterone. So since that's not working, you're going to have that being decreased. And because your pituitary still has hope, it still thinks it can push through a couple more years, the FSH and the LH are going to be high. Menopause symptoms, you guys know, long-term consequences, self-explanatory. Premature ovarian syndrome, the two things to know are Fragile X syndrome and Tanner's syndrome. And there's other things as well. All right, microbiome. Okay, we're pretty much at the end, and I think you've got another lecture now, so I'll just stop it for you guys now. The slides are up there. Microbiome is just a lot of memorization, really, but I've got all the tables up for you and highlighted for what you really need to know. And I've also got some clinical stuff there as well, just because clinical stuff is actually a really large part of the exam, but it's sort of not so much explaining, more taking what you know and applying it. So I'd look at amenorrhea, I'd look at contraception, which is just memorizing really, and I'd also look at breast cancer, and I've got the basics up there as well with some questions for you. All right, so you are free to go. Someone sent a question, so I just answered it. Do we need to know which follicle the zona pellucida, theca, etc. appear? Histology and physiology lectures are different things. One said that it appears in the primary follicle, another appears in the secondary follicle. Okay, I'll just skip back a lot to see if I can find it. To be honest, it would be a really small thing to know. So if you don't have time, I wouldn't go out of your way to learn it, but if you really want to make sure you know everything, by all means, work out which stage it is. Slides back. Okay. Okay. This is what I had in my notes, that the theca comes in the secondary follicle. it's just like an extra thing. I have it as secondary follicle. Maybe it is first, but that's sort of like, if you had to guess secondary. But it's honestly not a big fish, not a big important thing to know.
Thanks very much.
No worries.
Josephine. So, yeah, as I said before, this will go up on YouTube. So if you want to watch it again, and the slides are all in the MUMIS Google Drive. So thanks very much, Josephine. We've got another lecture now, so hop on that if you can.